Great. I'd like to thank the association for the privilege of the invitation. I'm going to take a relatively dry topic, preoperative medication cessation, but it is something that's certainly relevant in our everyday practice. These are my disclosures. I will use brand names selectively here, mainly really not as an endorsement, but to provide an aid in recognition. So the ERAS Cardiac Society has, over the last few years, developed turnkey order sets. You can see multiple different domains that many of the people on the panel and in the audience have been involved with. The most recent one that is being worked on is by Amanda Ray, who's a nurse practitioner in Maryland. We're looking at preoperative medication cessation. And the methodology for all of these turnkey order sets are to take at least 3 to 4 existing society-level guideline recommendations and to aggregate all Class 1 and 2A recommendations, put those together and identify those, and then take into account relevant 2B and expert consensus recommendations and formulate just a simple turnkey order set. You've seen some of the QR codes that have been attributed to it. There have been 4 sort of pre-op medication guidelines: the European guidelines, the American Cardiology, AHA, SKY guidelines, really with respect to antithrombotic medications, the STS and the SABM with respect to blood conservation, and then finally the Anesthesiology Association with respect to newer glucose management medications. So this is something that's a relatively new topic. My introduction to this topic was a 70-year-old cardiac surgeon in our group who called me last fall with a very strong Texas drawl, very angry. Why? I'm not going to try to do justice to the drawl because it's not really worth it. But why is anesthesia canceling my case? Because my patient was on Mounjaro. And so, this was sort of interesting. It's not something that I had really encountered, but there's a number of reports with respect to these medications. So in summary, the SGLT2 inhibitors and the GLP-1 receptor antagonists, not to belabor the point, but just for the sake of information, really these are 3rd and 4th line medications that are utilized to treat diabetes. But essentially what they have is some of them have selective benefits with respect to weight loss, SGLT2 with respect to heart failure, and the combination in the primary and secondary prevention of coronary artery disease and renal disease. And when you encounter these, because they have multiple different effects, GLP-1 receptor antagonists specifically have a risk of delayed gastric emptying, and the SGLT2 inhibitors specifically have a risk of euglycemic diabetic ketoacidosis in the starvation state, or in other words, what you can encounter at the time of surgery. So the Anesthesiology Society last year issued specific directives with respect to these medications. So the GLP-1 agonists, there are 2 types. One are those that are used daily and those that are used weekly. And so on the top column, you can see those that are used daily, both by generic and trade names. The recommendation is to hold those the day of surgery. So in other words, if you take it on, if your surgery is Wednesday, you're allowed to take it on Monday, but you shouldn't take it on Tuesday. With respect to the weekly drugs, you should hold it 7 days before surgery. So you can see they're pretty straightforward with respect to that. Now, how do you manage this? So if you have a GLP-1 agonist and somebody needs emergency surgery, on the right there's a detailed pathophysiology, how this can lead to euglycemic DKA. But it's important that your anesthesiologist, number one, recognize that this potential exists both in the operating room. They may manage this with glucose infusion, with insulin infusion. What's important is to check serum bicarbonate and anion gap and manage this appropriately. But it's critically important that in the handoff from the OR to the ICU, the team is aware that this patient was on this medication and they should look out for specific symptoms, specifically the euglycemic DKA. SGLT2 inhibitors. Here you can see a whole host of them. These are commonly used in the heart failure setting, but more and more you can encounter those. And in this situation, very similarly. With the SGLT2 inhibitors, you can see the different restrictions that you have here. Now, so the GLP-1 agonist, your risk here is the delayed gastric emptying. So the key to managing those patients is to make sure that they are not, that your anesthesia follows that safely. And the SGLT2 inhibitors, the key is to watch out for the euglycemic DKA. Finally, other medications here, you can see listed how the other diabetes medications are appropriately managed. Now, shifting gears to some of the antiplatelet and antithrombotic agents. Platelets, I think we have a lot more familiarity with this, probably over several decades. You can see here the specific methodology and guideline recommendations with respect to aspirin, clopidogrel, prasugrel, etc. This is really a comparison of the P2Y12 inhibitors and really the recommendations on when these medications should be discontinued is really related to the bioavailability and the duration of effect specifically. There's no specific reversal agents that treat these. How about with respect to anticoagulants? So you can see here with respect to warfarin, heparin, low molecular weight, and specifically, vitamin K antagonists. This I think we're all pretty comfortable with, typically holding the warfarin 4 to 5 days beforehand, selectively bridging some patients. With respect to the NOACs, very similarly, typically holds it at least 48 hours, and then dabigatran, which is not really that commonly used, typically 96 hours. So you want to wait at least 48 hours for these medications. This is an overall guideline recommendation. Aggregating all of that, you can see here between 7 days, you want to stop prasugrel, 5 days, stop clopidogrel, at 3 days, specific recommendations, and then sort of in the postoperative period, how to resume from there. Other medications that I think are of interest, the RAS inhibitors. So these are your ACE inhibitors and your angiotensin receptor blockers. So the question here is, does this lead to vasoplegic shock? And in general, the recommendation is you should hold this before surgery. The data is probably equivocal in terms of low-risk patients, but there's a pretty high-quality systematic review here that shows a pretty consistent increase in acute kidney injury with continuation of the ACE inhibitor or ARB. So the recommendation is to stop this 24 hours in advance. And again, this is really sort of a comparison of the different medications in these classes across the board to hold it for 24 hours. So finally, this is the European guideline or European recommendation of a number of different specific recommendations across the board with respect to all of these that you can see here. So I think the most critical take-home message is you have to ask the patients. Sometimes patients don't necessarily reveal exactly what medication they're on, and close communication between surgeon, anesthesia, and the critical care team. Thank you.